Dr. Birken's primary research interests are healthcare organization and delivery, the dissemination and implementation of innovations, quality improvement, and organizational behavior in cancer care. Most recently, her research has focused on the dissemination and implementation of survivorship care plans in U.S. cancer programs. In today's webinar, Dr. Birken will describe existing and planned research on implementing survivorship care plans in practice. Before we begin, I'd like to mention that this session is being recorded and the link will be provided along with the presentation slides to all participants after the webinar. The format for today's webinar will be approximately 40 minutes of content followed by some time for questions. You can send questions throughout the presentation by typing them in the chat screen, and the presenters will respond to these questions at the end. I hope you enjoyed today's session. On behalf of the Alberta SPORE Knowledge Translation Platform, I would like to extend a warm welcome to Dr. Sarah Birken, and I'll now hand things over to her.
Great, thank you so much. I really appreciate the opportunity to present for the KT platform, and am grateful for the opportunity to talk about the research that I've done on implementing survivorship care plans. Assuming that most may not have a common base of knowledge about survivorship, I'd like to begin by talking about, survivorship itself. So as the artwork on this slide suggests, getting through cancer treatment is a harrowing process, but many survivors indicate that the survivorship period can often be just as difficult. Survivors report being dissatisfied with survivorship care, which is not surprising in light of the fact that they often do not receive recommended services. In some cases, they receive duplicative services. And this may be due in part to lack of consensus among follow-up care providers, such as oncologists, primary care providers, regarding their respective roles in survivorship care. So it was with that in mind that in 2005, the Institute of Medicine, in its landmark report, Lost in Transition, made the recommendation that a common sense approach to handling these issues around survivorship was to develop and deliver to survivors and their primary care providers survivorship care plans. And a survivorship care plan is quite literally a document that is intended to get survivors, cancer care providers, and primary care providers and other follow-up care providers on the same page regarding what happened during cancer treatment and what needs to happen moving forward during the survivorship period. And a survivorship care plan is intended to include a summary of cancer diagnosis, treatment, and any treatment-related late complications, and then make some recommendations for follow-up regarding prevention, surveillance, and health promotion, such as physical activity and nutrition. It's fair to say that these recommendations from the Institute of Medicine were met with quite a bit of resistance and controversy, due in part to the fact that it wasn't until 2011 that there was a randomized controlled trial of survivorship care plans' effectiveness in achieving the goals that the Institute of Medicine set forth for survivorship care plans. And to go over the challenges associated with Grunfeld and colleagues' randomized controlled trial, I'll say that there were a few limitations that made these results inconclusive with respect to the extent to which survivorship care plans are effective. One limitation is generalizability. Particularly from Canada's health system to the U.S. healthcare system, there's simply less of a rift relative to the U.S. in Canada between Canadian primary care and oncology. In the U.S., we have a much more disjointed system in many respects. Another limitation of this study for understanding survivorship care plans' effectiveness conclusively is that it was conducted among breast cancer survivors who tend to be middle-aged women who are already well integrated into the healthcare system relative to, for example, men with testicular cancer who tend to be young and not well integrated into the healthcare system, and may therefore benefit from a tool to help them transition and navigate the health system. Another challenge were the outcomes that Grunfeld and her colleagues assessed. We can expect only so much of a piece of paper, and yet Grunfeld and her colleagues, similar to many other researchers, included outcomes that are unlikely to be influenced by survivorship care plans, such as patient satisfaction and quality of life. And to put a point on that, to put a bow on that point, I'll review existing randomized controlled trials of survivorship care plans effectiveness. And this is a very busy slide, and I'm sorry for that, but I'll just go through the columns of this slide to indicate the limitations associated with randomized controlled trials of survivorship care plans effectiveness thus far. And many of them will sound familiar because they have the same challenges that Grunfeld and her colleagues had. One is that the survivor groups that tend to be studied in these RCTs are breast and gynecologic cancers, which may systematically differ, as I mentioned previously, from other cancers. Another one that will sound familiar is the country in which these were conducted. These are very different healthcare systems, and there's a limitation on the extent to which we can compare the results of these trials conducted in these different countries. I also mentioned the outcomes assessed, and again, you'll notice that there are sprinkled throughout some process measures that may be fair outcomes to assess of survivorship care plan use, like coordination of care. But there's a lot around things such as impact of cancer and patient satisfaction. Another key concern about these RCTs is that we're really comparing apples to oranges. We as a field haven't really agreed upon what a survivorship care plan is. Is it simply a piece of paper, or is it a piece of paper plus an educational session or a provider visit? Does it need to be web-based? So our ability to compare across these studies is curtailed by the interventions that are being studied. Despite the lack of evidence of effectiveness of survivorship care plans, in 2012, the Commission on Cancer, which accredits cancer programs in the U.S. that cover nearly 80% of all cancer patients in the U.S., required survivorship care plan use as a criterion for accreditation. And this was followed by many other agencies that now either recommend or require the use of survivorship care plans. And so when faced with lack of evidence and these requirements, I can't help thinking about this study. And if you take a moment to read the headline, you'll notice this is tongue-in-cheek. And I'm not suggesting that survivorship care plans are so commonsensical that they don't require a randomized controlled trial. But I do think we need to think more creatively about the type of evidence that is required for understanding survivorship care plans effectiveness, and that has really guided the research that I'll talk about today. So my colleagues and I have published a couple of papers making the case that to understand survivorship care plans effectiveness, we have to understand its implementation. And the reason we say that is because survivorship care plans are a complex intervention. They're a complex innovation, which means that they require coordinated use by multiple organizational members to be used. This stands in contrast to a simple innovation or intervention, such as a pharmaceutical. You take a pill, it either works or it doesn't. There is user error, but it's much less complex organizationally than implementing something such as a survivorship care plan. So we argue that understanding that process is critical and has important implications for the effectiveness. If something is not implemented well, its potential benefits will certainly not be realized if there are any to be had. So I had the opportunity in collaboration with my mentor, Deborah Mayer, to critique a recent randomized controlled trial of survivorship care plans' effectiveness. And one of the compelling reasons that I agreed to help Deb and our colleague Ron Chen write this paper was one statistic from this paper, this trial, and that was that there was a survivorship care plan intervention arm, and there was a control arm. And in the intervention arm, 30% of primary care providers reported not receiving a survivorship care plan. And that, to me, suggests a big problem with implementation, because we can be sure that since they were in the intervention arm, something happened, but perhaps it wasn't potent enough to make a difference. So what am I talking about when I refer to implementation? I would adopt the Klein and Sora definition, which refers to the proficiency, the quality with which something is used, and the consistency with which it's used. And then in the context of survivorship care plans, proficiency refers to the extent to which the care plans include recommended information. And there's actually updated evidence suggesting that the proficiency of survivorship care plan use is quite limited. They tend not to include recommended content. With regard to consistency, my colleagues and I found that survivorship care plans tend not to get to all survivors, and even less frequently, they get to primary care providers. And again, if survivorship care plans are not reaching their intended audience, they simply cannot have any influence on outcomes that we hope to achieve with survivorship care plan use. So here began my journey of understanding what is influencing whether or not survivorship care plans are implemented. In a review that Deb Mayer and I conducted along with our colleagues, we identified several studies that investigate determinants of survivorship care plan implementation. I won't highlight all of these, but I'll draw your attention to electronic health records to make the point that a lot of literature points to electronic health records as a means of automating survivorship care plan use to get over the hurdle of the substantial time it takes to develop a survivorship care plan. And you can hang on to that idea for as I move forward in this presentation. It will be relevant. So my colleagues and I have conducted several studies related to survivorship care plan implementation. And we find things at the organizational level, the cancer program level, related to things like geographic location, there are clusters, program type, academic hospitals tend to do better with this. But I was interested in more granular understanding of what influences survivorship care plan implementation. And so I conducted a study in collaboration with Justin Perceau, who is at the Ottawa Hospital Cancer Institute. And we used the theoretical domains framework, a comprehensive framework for understanding healthcare professionals' behavior, to try to understand why healthcare professionals do or do not use survivorship care plans. And the benefit of this is, in contrast to the previous studies, which were relatively idiosyncratic in their identification of potential determinants of survivorship care plan implementation, we took a wide open approach to understanding what might influence healthcare professionals' use of survivorship care plans based on our broad theoretical understanding of healthcare professionals' behavior. And what we found was this. There's a lot of variation in providers' beliefs about whether or not survivorship care plan use is beneficial to survivors, primary care providers, or themselves. And that influences whether or not they're willing to use survivorship care plans. We also found that, of course, providers have competing task demands. Many cancer care providers use survivorship care plans as a small part of their much bigger job. And particularly if the provider views survivorship care plans as not useful, not beneficial, they're very unlikely to use them. Another potential determinant that we identified in these interviews that we conducted was the environmental context and resources. Was there a strong implementation climate, essentially, for survivorship care plan use? Was it prioritized? And were there things like schedule blocks? Does a provider have the autonomy necessary to block off his or her schedule to use survivorship care plans, to deliver survivorship care plans, or to develop them? Another potential determinant that we identified is essentially zeitgeist, the extent to which the provider views survivorship care plans as the right thing to do. Within their peer group, is it viewed as the thing to do for a survivor? I presented the results of that study that I just went over at a conference about a year ago, maybe a little more, a couple years ago, and a colleague approached me and said that she wondered, with such poor implementation, whether people had guidance, whether providers had guidance about how to use survivorship care plans. Because without guidance to use survivorship care plans, she was suggesting they're not going to be used. If you don't have information about how to do something, you won't do it. So she mentioned some research by a colleague of ours, Amanda Nelson, who does work in osteoarthritis. She used the AGREE-2 instrument to evaluate the quality of guidelines for the treatment of osteoarthritis. And she suggested that I might use the same tool to evaluate guidelines for the use of survivorship care plans. And in this study, my colleagues and I identified 16 guidelines internationally for survivorship care plan use. And we did this with a literature search as well as expert recommendations regarding any additional guidelines that have not been identified in the literature search. And you can probably feel the punchline coming. The guidelines were overall very poor quality. In addition to not being very clear about what the guideline was for and the populations to which it applied, these guidelines were very poor in terms of the guidance they offered in terms of implementation. How do you make this happen? So I'm engaged in several studies currently. I'm just completing a pilot study funded by the Cancer Research Network regarding stakeholders' perspective on survivorship care plan implementation and outcomes. And if you recall, there are a couple of critiques that I made of extant randomized controlled trials. One is that it doesn't take into account implementation, and they haven't taken into account outcomes that are likely to be influenced by survivorship care plans. And my colleagues and I thought that a really wonderful way to get at this issue would be to simply interview stakeholders regarding their perspectives on implementing survivorship care plans and outcomes that they view to be valuable. So my colleague Erin Hahn at Kaiser Permanente in Southern California and Robin Urquhart at Beatrice Hunter Cancer Institute, we collaborated conducting these independent but coordinated studies of stakeholders' perspectives on survivorship care plan implementation and outcomes in our respective healthcare systems, which is particularly interesting because this spans two very different parts of the United States and Canada, one health system within Canada. We've completed 26 interviews to date with a variety of stakeholders. Cancer program administrators who certainly have a stake in whether or not their cancer program, for example, is accredited. Cancer care providers with multiple clinician types, primary care providers, survivors, and caregivers of survivors. And we asked these interview participants in each of these healthcare systems about current existing implementation processes and strategies versus the ideal, and then survivorship care plan outcomes, what they've experienced versus the ideal. And what we found with respect to survivorship care plan implementation is that there is huge variation in the content of survivorship care plans and how they're delivered. There's simply no systematic method or workflow for the implementation of survivorship care plans. Any systems are driven primarily, it seems, by accreditation requirements and not necessarily patient-centered care. These are generalizations, I should note, but certainly it was a remarkable finding that these three very different health systems we found in each of these health systems. We were interested in the extent to which any of these health systems were using implementation strategies. So planning, training, financing, these sorts of things. And what we found is that there were really non-strategies. In fact, my colleague, Byron Powell, here at UNC, is he's an expert on implementation strategies. And so I talked to him and I said, what do you call a strategy that it isn't really intended? And he said, Sarah, that's not a strategy. So really what we're seeing is catch as catch can. For example, we found that many providers simply rely on their memory to identify a survivor who's eligible for a survivorship care plan. And in the midst of their many task demands, it falls through the cracks. We also found that survivorship care plan implementation systems really rely on one or two dedicated staff. And there really isn't clear responsibility, delegation of responsibility for the delegation of tasks in developing and delivering survivorship care plans. And so this leads to very inconsistent survivorship care plan implementation. I can tell you at UNC, for example, we have very few providers who develop and deliver survivorship care plans, and when they take leave, survivorship care plans don't happen. With respect to outcomes, a remarkable finding is the consistency of these different stakeholder groups' views on what they want from survivorship care plans. They want communication regarding what happened and what needs to happen moving forward. And a lot of this relates to staving off fear, patient's fear, survivor's fear of recurrence for new cancers, and the challenges associated with any late effects. And then providers' fears, primary care providers' fears that they won't catch a recurrence or a new cancer, and that they won't administer appropriately timed prevention and surveillance. In terms of the actual outcomes, it seems as though survivorship care plans simply aren't being used in a way that's meaningful. Cancer care providers simply lack the impetus and resources to use survivorship care plans in a meaningful way. And survivors and primary care providers seem to want the content that a survivorship care plan promises, but the actual implementation of survivorship care plans diminishes their potential. For example, I have heard several survivors tell me that they received survivorship care plans at a suboptimal time. One survivor said that she would have really preferred a survivorship care plan before radiation because it would have staved off some of the concerns that she had. I was speaking with a cancer care provider who told me that part of the reason that she doesn't deliver survivorship care plans to primary care providers is that she simply knows that they're not going to get it at a time that is meaningful. Cancer care providers send the survivorship care plans when they're done, and they that doesn't necessarily come for the primary care provider at a useful time. It's not typically at a time that around the time when they're supposed to see the survivor in their clinic. I'm also conducting a study funded by our CTFA here, our Clinical and Translational Sciences Institute here at UNC. We call it NC Tracks. My colleague and I at Research Triangle International, Sarah Jacobs, are using qualitative comparative analysis to identify strategies for the successful implementation of survivorship care plans. And we're conducting this in the Quality Oncology Practice Initiative, which is part of ASCO, the American Society of Clinical Oncology. These are cancer programs that theoretically are the cream of the crop because they are actively engaged in quality improvement in their cancer program. We are using secondary data to identify cancer programs that exhibit varying levels of treatment, they use the term treatment summary, so apologies for the confusing acronyms. You can just substitute TS for SCP. We're looking to identify what's happening in the upper left quadrant. What are the people who are developing survivorship care plans consistently and proficiently and delivering them proficiently and consistently doing that we can leverage for other cancer programs. And I should have mentioned that qualitative comparative analysis uses basically Boolean algebra to identify patterns in data. And this is particularly useful for small samples, such as ours. We're interviewing cancer care administrators and providers in 20 cancer programs, and there may be multiple participants per cancer program. I had another point about qualitative comparative analysis. It's also nice because it allows for the idea that determinants may influence in one direction. So regression analysis makes the assumption that more of any determinant is helpful or not helpful, and less of it is the opposite. And qualitative comparative analysis does not make that assumption and looks at each determinant and its directionality independently. So here are very, very preliminary findings. We just got this study off of the ground. We've conducted, I think, 6 interviews. But so far, here's what we found. There are 2 basic models for survivorship care plan implementation. There's a devoted champion who has volunteered to lead this effort, or a person to whom the task has been delegated. And in some cases, it seems as though that person is willing and excited, didn't necessarily volunteer, but is okay with doing it. And in some cases, these people are not terribly willing to be taking on this very quite substantial project. Regarding strategies, again, these are very preliminary findings, but I'm drawing on a couple of interviews that have indicated this idea of automatic versus reflective processes, and which sounds very geeky and theoretical, but I'll bring it to a practical place. So one interview participant said that she initially lamented that they weren't able to implement an electronic health record-based clinical reminder to let a provider know when a survivor was ready for a survivorship care plan. But having to work around that limitation, she and her team were effectively forced to meet, to talk through their system, to identify and devote scheduled time for developing and delivering survivorship care plans, and regularly meeting to revise those plans as their clinic changes, as things evolve in their cancer program. And this interview participant indicated that reflective process really brought wonderful nuance and meaning to the way that they're implementing survivorship care plans. In contrast, and again, I'm drawing on 1 or 2 interview results for this, so take it with a grain of salt. But the systems where there is low development of survivorship care plans and low delivery seem quite convoluted. There are many opportunities for things to fall through the cracks. There are many handoffs among providers, and there's very little consistent delegation of responsibility. So I'm in the midst of writing an application for, excuse me, our Career Development Award, where I'm drawing on principles from industrial engineering and human factors engineering in particular, to get training in human-centered design. And I've termed it for my purposes stakeholder-centered system design. So that's SCSD on the slide. And to introduce you to the concept of SCSD, I like to give the example of Swiffer, you know, the mop that's not a mop. The way they developed Swiffer, or so the story goes, was that researchers went into customers' homes, had a cup of coffee, and accidentally spilled the coffee. And they looked at what people did in response to the spilled coffee. And as you or I would do, they got a wad of paper towels or a cloth, and they got down on their hands and knees and they wiped up the spill. Nobody brought out a mop because mops are cumbersome and you have to wash them. And so Swiffer essentially designed a cloth, a disposable cloth on the end of a mop. So the principle here is, instead of asking users to accommodate a system, SCSD adapts the system to accommodate the needs of stakeholders. And so that's what I'm proposing to do in my Career Development Award. And I'll go into detail here. So in my first aim, I will, at UNC Cancer Hospital, design survivorship care plan implementation systems that accommodate the needs of stakeholders. And I'll apologize here. My application is a moving target, and so these are a bit off, but please know that the stakeholders that I include are also cancer program administrators and primary care providers, in addition to survivors and cancer care providers. But the idea behind SCSD, Stakeholder-Centered Systems Design, is to engage stakeholders to understand the current process and their needs, and any challenges with the current implementation system, what they believe to be the problems. We also use observation to identify things like task load, how difficult it is to engage in a task. And the goal of this process is to minimize the burden on the users. How difficult is it for a cancer care provider to develop a survivorship care plan or schedule a visit to deliver one? How difficult is it for a primary care provider to access the survivorship care plan in the electronic health record? Is the timing right? That sort of thing. And so we, in the third step, propose changes, and in the fourth step, test those changes, and then evaluate their influence on the effectiveness of the system in promoting survivorship care plan development and delivery. And then we repeat that process, continuing to identify concerns and potential improvements until stakeholders report being satisfied. And in this is it demonstrates one of the many tools that are used for SCSD. This is a stakeholder map, which allows us to understand relationships among stakeholders in the implementation process. There are also things such as process maps that allow us to visually depict the process and identify concerns that way, and to solicit feedback from stakeholders regarding the accuracy of our depiction of the system and opportunities for improving the system. And in the second aim, we proposed to develop STARS, which was a hard-fought acronym. It's a bit of a stretch, but it rolls off the tongue. and it's a toolkit for designing systems that facilitate survivorship care plan implementation. So the premise of this is that we know that the method that we use and the system that we devise at UNC is very unlikely to be what another cancer program needs. In implementation research, we acknowledge that context is very influential. To empower other cancer programs to design systems that address their own stakeholders' needs, STARS will allow them to go through this process of applying SCSD principles to allow them to understand their stakeholders and to address their needs. Developing a survivorship care plan implementation system that addresses those needs and optimizes survivorship care plans. And in the third aim, we'll pilot test the implementation and effectiveness of STARS. So in a nearby cancer program, a community cancer program, unlike our academic cancer program, we'll look at the feasibility, acceptability, and cost of implementing STARS, and we'll use surveys to do most of that. And we'll use electronic health records to evaluate the effectiveness of STARS in improving survivorship care plan development and delivery. And during the process of conducting the proposed research, I'd like to investigate a nuance which is based on my preliminary studies that have found that survivors and primary care providers and other stakeholders want different content in their survivorship care plan, or I suppose I should say it should be phrased or framed in different ways for different people. There are issues around literacy, health literacy. Some content in survivorship care plans, depending on who develops it, can be quite technical and use a lot of jargon that is unhelpful to survivors and their caregivers, but may be very helpful to a primary care provider. And a primary care provider, some studies have suggested, want more information about prevention and surveillance screening schedules versus a survivor who may be more interested in what kind of health behaviors they can engage in to minimize the risk of recurrence or new cancers. So the objective of writing a developmental grant application is to determine whether we can tailor survivorship care plans to different recipients' needs without placing a burden on cancer care providers. It's cumbersome enough to develop one type of survivorship care plan. It would be a shame to ask cancer care providers to develop multiple kinds. So if we can leverage what we find in my proposed Career Development Award application to understanding how we can achieve these patient-centered and stakeholder-centered objectives, that would be ideal. And so I'll end with just a couple more slides. This one is my long-term goal of conducting a hybrid study of survivorship care plan implementation and effectiveness. And this addresses the concern that I have regarding extant randomized controlled trials that suggest that don't account for the influence of implementation on effectiveness. So in a hybrid study, you can simultaneously assess implementation and effectiveness. And this would involve assessing implementation, assessing the influence of survivorship care plans on outcomes that are relevant to stakeholders as identified in my preliminary studies. And in the third aim, look at the extent to which implementation moderates survivorship care plan effectiveness so that we can perhaps boost the positive effects of survivorship care plans with optimal implementation. And so I'll end just by acknowledging what I view to be the elephant in the room, and that is that survivorship care plans, I suppose I've said this before, they're just a piece of paper. And they really are intended to do something much bigger, and that is to improve survivorship care. It is not reasonable to think that a piece of paper can do the work of a comprehensive program of survivorship care. But I view survivorship care plans as an opportunity to better understand systems of care and how cancer care providers collaborate or not to implement an innovation so that we can understand not only survivorship care, but cancer care and all types of health care more broadly. So I'll stop there, and I believe this may, oh, I should mention, I should acknowledge many people and a couple of things. One is mentor training for dissemination and implementation research in cancer. This is a fellowship that I participated in. I suppose I ended about a year ago. It's a 2-year program, and it is excellent for those of you who are interested in dissemination and implementation research and cancer care. This is an excellent way to get mentoring, and not only from experts in the field, but also from just a wonderful network of researchers in this field, peer researchers. And of course, I want to acknowledge the many people who worked with me on this research and my funders. Okay, and I think that's now it. I think this may be the time for questions.
Great, thank you very much. Does anybody online have any questions for Dr. Birken? You can put them in the chat, type them into the chat area. Can they also come off the page? Or is it just the chat? Okay.
Well, maybe while we wait to see if people are typing in questions, I'll ask something that cropped to my mind. Just you mentioned doing some work with Justin Presso, and that got me wondering if you had in your research had occasion to notice any differences between the U.S. and Canadian healthcare contexts in terms of implementation, or whether that has, this may be totally not something you can answer, but if you have, I was just curious about it.
Well, so in the study that I'm conducting with Robin Urquhart at Beatrice Hunter Cancer Institute, I was very surprised to see that there don't seem to be, I tend to put Canada on a pedestal in terms of its healthcare system in some respects, and I tend to expect things to go better in terms of implementation because it seems like it's so much more organized than our U.S. healthcare system. But for reasons that are unknown to either of us, it does not seem as though survivorship care plan implementation is happening any better in, at least in that one institution. It does seem that the same challenges exist there.
And another question I have is, I'm fascinated by your mention of using principles of user-centered design or human-centered design. I don't remember exactly what you called it. Can you tell me a bit more about sort of that body of work and how you drew on it?
Yes, absolutely. I'm very new to it. I'm proposing to get training in it. I have none currently, so everything I say, take with a grain of salt and know that I may not be accurate. But I'm working with several wonderful researchers whom I've been connected with, both in Canada and the U.S. Who've introduced me to the topic, and I'm muddling through trying to understand, but there are, a lot of it seems to relate to electronic health records or to user computer interface and optimizing things like where things are located in the electronic health record and making it as user-friendly as possible for people to find the information that they're looking for. You know, I think about that anecdote that I mentioned of the cancer care provider who doesn't deliver survivorship care plans to primary care providers because they know how convoluted it is to find an electronic health record. And in fact, somebody described to me where it is at UNC, and it is in fact very convoluted. So it's there, it's just buried. So working to optimize location. Another thing that I've learned about with respect to human-centered design is workflow optimization. So I mentioned with some of my research in some underperforming organizations, there are simply many opportunities for things to fall through the cracks. There are lots of handoffs and they don't happen consistently. So workflow improvement can be used to minimize those handoffs and to build in redundancies to ensure that the handoffs have happened appropriately and accurately. Another thing has to do with, you know, I mentioned an electronic health record clinical reminder. In one case, somebody being glad that it hadn't worked out, but we have found that cancer care providers do tend to rely on their memory, and if they rely on their memory, and like the rest of us humans, they get bogged down with competing task demands and they forget, we may be able to optimize a clinical reminder and using rapid cycle experiments to understand the influence of a pop-up reminder during the visit versus an email a day or two ahead of the visit to the provider, and experimenting to figure out the optimal method of reminding without being one of those pop-ups that a provider gets a barrage of and simply clicks out of as quickly as possible to get to the work that they actually need to do.
Okay, yeah,
that's my
really
uneducated answer.
Sure. Okay, so we've had a question come in written in, and that question is, what kind of research methodology, i.e. ethnography, are you looking to use as part of your human-centered design research?
Yeah, that's a great question, and it's taken me a while to center on it. And I think what I've landed on is, I think there are many ways of doing it. The method that I've landed on is drawing from all of the stakeholder groups that I've mentioned. So primary care providers, cancer care providers, survivors, caregivers, all of these people, and interviewing representatives of these people, one or two, and analyzing as you would in any qualitative research to identify features of the system first and foremost, and then to identify concerns that those stakeholders have regarding the system. We'll also use observation to better understand what the system looks like to complement the interviews. And once we have a clear process map of the current system, we'll bring together representatives from those stakeholder groups in a 2 or 3 hour retreat where we will give them the opportunity to provide feedback on the process map and to identify potential solutions. I have a mentor, Noah Segal is a researcher at Duke in the Department of Anesthesiology, and she's a human factors engineer. She and I will be working to identify, with my expertise in implementation and Dr. Segal's expertise in human factors engineering, which of the proposed solutions, stakeholder proposed solutions, are likely to influence the system in a positive way and are likely to be implemented. and we'll go through an iterative process of testing proposed changes. We'll also prioritize addressing concerns that are frequently mentioned and that are likely to most directly influence survivorship care plan implementation. And I'm trying to think of an example of what that might be, but something may be, and I'm making this up, difficulty getting, well, I'm not really making this up, this is an anecdote, it's not from a study, but I spoke with a provider who indicated that it's really hard to schedule a visit for a survivor in our cancer program. Just getting them on the schedule is extremely difficult. There's very limited provider availability. So that will influence survivorship care plan implementation. So that would be one of the priorities for us to address.
Okay, so I don't know if everyone is able to read the notes, so I'll read out another one that has come in. It says, thank you for your presentation. If anyone is interested in the work Alberta Health Services and Cancer Control Alberta is involved in now on developing and implementing a provincial approach to transitions in care, including care plans and implementation processes, please feel free to contact Shelley Curry at shelleym.curry@ahs.ca. And she notes she's also part of a pan-Canadian network of health systems leaders who are working on this in their healthcare jurisdictions. So thanks, Shelley, for that. And also there's a question about the sharing of this presentation, and so I'll just mention that everybody who is registered for this this webinar will get an email afterwards, which will include a link to the archived recording of this webinar.
And thank you, Shelley. I will absolutely contact you. Thank you for letting me know about what you're doing. I'll be excited to talk with you.
Good. Yeah, always a nice feature of these presentations when we were able to build the network of people working in this area. Okay, I don't see any more questions being typed in, and we don't have any more questions from the people gathered here in person in Edmonton.
Sure. Well, I'd like to take this opportunity to thank you, Dr. Birken, for your very interesting and thought-provoking presentation. And also another thank you to the webinar participants who joined us. And as Denise mentioned, this session is being recorded, and the link to view the webinar will be emailed to all registered participants. And we'll also include a link to sign up for our KT Alberta newsletter, where we share information about upcoming events and activities such as this webinar. So on behalf of the Alberta SPORE Knowledge Translation Platform, I'd like to wish everyone a great afternoon and hope you'll join us again next time. Thank you.
Great. Thank you so much for having me.